Thank you for the invitation. It's a great pleasure to be here. I do not have any disclosures with regard to my talk and any other external fees for the clinical trials or the advisory meetings are used for the undergraduate student research. So I'm going to probably, I quite, in the morning session, I quite like the question answer session actually. I might just kind of slightly see if I can shorten my presentation and maybe allow a bit more interaction later on when we all finish. So I'm going to just give a brief overview of epilepsy and Rett syndrome, some of the challenges in diagnosis and treatment, my own clinical experience, and there are a couple of pieces of work which we are doing in Edinburgh in terms of strategies to improve epilepsy care, in generally with the epilepsy community, but in specific to Rett syndrome. So as you may know, epilepsy is fairly common in Rett syndrome. It's about 60 to 80% depending on the literature looking at it. If you have an early onset epilepsy, it's slightly less favorable outcome. The main challenging thing is it's a multiple types of seizures, and some of which may go unrecognized for quite a long time. And one of the challenges along with the clinical diagnosis of epilepsy is the investigations, and I will talk a bit more about this because this is the part of work which we are doing in Edinburgh to see whether we can improve this. Getting an EEG, some of you who have been in the hospital, getting an EEG done is quite challenging in children with Rett syndrome. And the selection of treatment can be challenging because which drug to use, and I'll address a little bit of that. And I will also touch a little bit about non-drug treatment actually. So what are the other alternatives? And there is very limited data on Rett syndrome at the moment. However, it's really important to know that there are only 15 to 20% of the children who have epilepsy which achieve a complete remission. That means if you look at the general epilepsy community, if you diagnose epilepsy, out of 100 children, you would say probably about 60% of the children with 2 years of treatment become seizure free, and then that's the end of their epilepsy. But that is not the case in Rett syndrome. That means there is a longer term burden of epilepsy in children with Rett syndrome for a long time, of which about 15 to 20% are treatment resistant. For these children, there can be quite a frequent hospital admissions, frequent changes in the treatment. So it's a fairly difficult treatment. So why are we talking about epilepsy today? We are talking about gene therapy and other clinical trials. I think it's really important time to talk about it because it's one of the challenges during the clinical trials some of us have experienced is that the new treatments may have an interaction or while we are monitoring for treatment-related adverse events, there may be unrelated to this, children might be admitted to hospital frequently, and that adds to the discussion we had in this morning is that there are lots of adverse events which may or may not be related to treatment, and sometimes teasing that out will be quite difficult. So what are the seizure types you'll get? I will not go into a lot more details because the seizure types reported in different papers, you can have almost every single seizure types in epilepsy. You could have a generalized seizures, that's involving the whole body convulsion, or you could just have a limb jerking, clonic jerking, or you could have a initial focal seizures and then becoming secondary generalized. Some of the examples I've given here actually it's from the paper and also from my clinical experience is that children might just have just a fixed gaze and then just go blue around the mouth and just a twitching around the mouth. That might be the only seizure. Or you could have just a head deviation to one side and there may be a gaze and then may lead to arm jerking. So there are different types of seizures, but these are probably the top 4 or 5 of them are easy to recognize because there is what we call a motor component or there's some movements associated with that. The ones which are difficult to recognize are staring and unresponsive episodes. Is it a behavioral change? Is it an epilepsy? Or those type of seizures. Sometimes you may just simply have an excessive tiredness. So basically if a child is having a seizure at night, there may be not enough daytime energy. That might be the only sign you might see actually, the child having seizure at night. So you may not recognize any seizures, but the child is really tired and that might be the only thing you might notice. So I think this is really crucial, understanding the triggers, not just the seizures itself. So infection, as we know, is a very common trigger for children, particularly younger children in the nursery age group. And understanding this is really important because sometimes along with your anti-seizure medication, you may have to have a plan that during an infection you might need to have a rescue treatment. For example, the children whom I look after, I will have a separate clobazam or a short course of benzodiazepines when they become unwell. Then the sleep problems. Now this is kind of quite a difficult conundrum. If you do not sleep very well, you have an increased risk of having seizures. And if you're having quite a lot of seizures, you do not sleep well. So it's basically adds to this cycle of sleep and seizures. Is a really complicated issue to resolve sometimes. The number of children with Rett syndrome will have gut problems. So if you have a constipation, that has an impact on the treatment absorption of the anti-seizure medication, that has an impact too. But one of the major issues which over the years we all know is that the puberty and its influence on the seizures, and particularly there are a number of factors with regard to puberty, the hormonal influence itself, and then also some of the anti-seizure medications may be less available, or if you use the oral contraceptives and some of these have an interaction with anti-seizure medication, it's really important aspects to think about. And then the interaction with the seizure medication and the other medication which you use. Obviously, both we are talking about the trials and also you might be on other treatment, there may be interactions as well. Post-Brexit, one of the things which we are all struggling is that getting the anti-seizure medications on time. It's just you're on a certain anti-seizure medication, on a liquid preparation, suddenly there is not enough supply of this medication. And change of these medications can have an impact on these things. So planning these things is really quite important. So getting back to a little bit about recognizing seizures, this is one of my students, Megan Hutchison, did a really wonderful study actually. So one of the common complaints we had from the parents with Rett syndrome and other community with intellectual disabilities that people are not good at recognizing the seizures, or people are sometimes not recognizing seizures, they are not seizures. So she did this really good qualitative study interviewing number of parents to say, what is that, how do you think is it difficult? And in fact, the clues are knowing what is normal, because parents do know, the mothers do know, they're just trusting the mothers actually, knowing what is normal. And being one of the common theme came out is being in tune to your child. You know what is not normal. This is normal to her, but this is not normal to her. Just being in tune to her. And the second theme is the seizure recognition by mothers, healthcare professionals, and some of the subtle things like the eye changes, which parents recognize very early on, and the healthcare professionals do not recognize. And obviously, the nature of seizures and extent of disability, and that's sometimes when you come to the emergency department, some of the seizures may be missed in children with Rett syndrome is because people may not be clear about how to recognize seizures if you have a quite fairly significant disability. So I'm not going to read all these things, but I can share this paper actually. It's really helpful summary from the parents is just listening to the family is actually one of the most crucial thing. And based on this, what Megan recommended from discussing all the families, that having a video-based care pathway. So how do we tell health professionals what the seizures is? That having a videos of a seizure of a child to say this is what her seizure looks like, and this is not what a seizure. So what we suggested is that having a video-based care pathways can be a simple solution for this. Talking a little bit about EEG. There are significant practical challenges. Going into hospital with, is not easy, and then getting an EEG lead supplied is not easy, and there are lots of other practical challenges. Simple like finding a parking space can be difficult sometimes. So there are lots of practical aspects of EEG changes, and majority of the EEGs are done short term. During that time, you may not have a seizure actually, so you may not recognize the seizures. And then some of the background abnormality in the EEG, so that your brainwave activity may be abnormal, that may not be related to epilepsy. And of course, we all know that there is a long waiting list currently in NHS for longer term EEG. So moving on I'm going to talk a little bit more about some of the work which we are doing with regard to EEG, and I'll probably hear more of this. But this is the landscape of the treatment available for epilepsy in general. over the last 150 years. And so particularly you will see over the last 10 years, there is an exponential increase in the number of anti-seizure medication available. The reason I'm showing this is because this is the systematic review done by our colleague Sam Amin and his group in Bristol. These are the treatments used in children with Rett syndrome. So that there is a large number of these newer medications which may or may not be working is not being used. Sodium alproate, levetiracetam, and carbamazepine are some of the common drugs used. Now, it may not work for everybody with seizures, but some of these newer drugs might be beneficial for some children who are resistant to treatment. So talking about treatment, I mentioned that I'm going to talk a little bit about non-drug treatment. I don't know, some of you may have heard about ketogenic diet, or maybe you young people may be on ketogenic diet. This is quite a historic treatment, really. More than 100 years ago, the surgeon in the US thought fasting is a cure for epilepsy, and he wrote in the New York Times at that time that the fasting cures epilepsy. That's because he noticed that the people who are fasted for a surgical list were having a better seizure control. But for many years then it became less popular, and nobody's really given a big thought into that until this happened. Has anybody seen the movie First Do No Harm by Meryl Streep? Yeah. So this is Jim Abraham, the Hollywood director, whose son Charlie Abraham had drug-resistant epilepsy, several anti-seizure medication, epilepsy surgery, but his seizures did not get better. And then he went and did some work to look at ketogenic diet, and then his son became seizure-free. And there was an NBC daytime series during that time, and also there is this movie about First Do No Harm. And then he set up a foundation called Charlie's Foundation on ketogenic diet. And that's kind of the history of ketogenic diet. Now it's a really well-established treatment in epilepsy over the last 20 years or so. And what is the evidence for this medically? Obviously, we do not believe in anything unless we have a clinical trial. So this is a clinical trial done in Grey Ormond Street Children's Hospital actually about 12 years ago. So when we were all registrars, this is one of the trial published. So what they've done is basically they've had a group of children who had fairly severe epilepsy, and half of them got into ketogenic diet and half did not. What they found is basically, and if you can see here, there are about 7% of the children had more than 90% of seizure reduction. But just to give an example, these are the children who have very refractory seizures. And then about 38% had more than 50% seizure reduction. And I'll showed you the big list of anti-seizure medication. There is none of the medications had that kind of results. There is not a single medication had this kind of result. But it is becoming a problem, because obviously this is not a drug and you need a dietitian, and it just takes a longer time. So this is actually one of the well-established treatment. And this has become a part of the NICE guideline and part of the SIGN guideline as in Scotland and NHS England as the treatment option for children who have drug-resistant epilepsy. Why I'm mentioning here in Rett syndrome, anyway, this is one of the charities based in the UK. Matthew's Friends is some really useful information if you wanted to have a look at that. Matthew's Friends is a charity supporting ketogenic diet. The reason I'm mentioning is that I was trying to look at what evidence do we have in children with Rett syndrome. There are only case reports of few children of ketogenic diet being used in the Rett syndrome. And I think it's really important that we need to be mindful that there are other treatment options that are available when the drugs do not work. So, talking about all the challenges of recognition of the treatment, difficulties in investigations, some of the challenges of the treatment, I want to talk a little bit about some of the work which we are doing, and then what we think could be the potential solution as a community we could do. I think in terms of seizure recognition, I clearly think videos are much more helpful, and then particularly work with your neurologist to see what are seizures and what are not seizures, and so that when you are presenting to an emergency department or seeing another healthcare professional, you could just basically show these are her seizures, it so looks like. And I will touch a little bit about the EEG at home. And I think, as I mentioned, we need to think about widening treatment options. And I've already been speaking to some of the parents that there are some treatment works for some children and it doesn't work for the others. And I think we need to understand this better by, as Dan suggested, and having a group within the UK, we could look at what treatment worked for which children, and then that's so that we could have a care pathways or individualized treatment. And I think having an individualized treatment pathway for your child is actually much more important than having these are the list of the drugs available, these are the list of the drugs. So that's only we can learn from the Rett community to say what worked well for children, and we will come back to you about that. So there are two pieces of research which we are doing in Edinburgh at the moment, in Scotland. One is the videos, which is during COVID, lots of bad things happened. There are some good things happened too. So suddenly when COVID happened, we couldn't see children with epilepsy. So Professor Zubairi, one of my colleagues in Glasgow, worked with a company called We Create, and we set up a secure video transfer service. This was largely mainly because we could see because of the NHS governance, he couldn't send the videos to the clinician. And at that time, it was set up mainly as a clinical service, and then suddenly, he's really astute in these things. Actually, Professor Zubairi thought, how about if we set up a consent process for the families who are sending the video, that whether you would be happy for this video to be used for teaching and research purposes. We have over 20,000 videos now actually of the seizures. So we're working with colleagues in Glasgow University to see whether we could use machine learning algorithm to look at some of these subtle features of the seizures to recognize these features. And that's being led by Professor Zubairi and his group. Some of the work which we are doing is looking at remote EEG monitoring. As I mentioned, there are some challenges in trying to bring children with epilepsy to the hospital. And we have a couple of colleagues in the Edinburgh University, a neuroscientist who has an expertise in machine learning algorithm. He does mouse model work on a gene called SYNGAP1 gene, and he's particularly keen on looking at the sleep pattern. Apparently, it's very hard to get mice to sleep. So he implants these electrodes on these mice, and then he needs to get the data when they sleep. And obviously that captures a large amount of data, and he's designed this machine learning algorithm recognizing the EEG. And I thought that was really good idea. And so this is a complicated algorithm. We worked with a group called UK Infantile Spasm Society to see what are the challenges of getting an EEG. This is what they said: when their baby has a seizure, they call an ambulance, or they go to a GP, or they go to health visitors. Sometimes you get sent to hospital, sometimes you're sent back. Sometimes you go to your pediatrician, or sometimes you go directly to the neurologist. It's a very complicated pathway for the families to get this EEG, and then we thought this would be a good model to think about setting up a parent directly recognize having a seizure, and if they see anyone, they directly referring this to the specialist service, where we develop an EEG cap, basically, which parents can apply at home, and the EEG will be transferred through the Bluetooth service, and that will be using a machine learning algorithm, we recognize these seizures. We are in a very early stage of this research. So what we're generally doing at the moment is we have EEGs in our own service for the last 20 years. We're training this machine learning algorithm to see whether we can pick this up. I'm going to just show you some very early data. These are the two engineers who are working on this. So it's, the process is basically, we are taking the hospital EEG system and feeding this to a machine learning algorithm, and then trying to see if we can recognize seizures. We also have control data, because there are a lot of babies get referred as they're suspected to have epilepsy, and those who do not have epilepsy. This is very early on. I'm not going to spend a lot of time, but we are getting reasonably good result. So when I say reasonably good result, it's about 70% accuracy. But obviously the number we are getting is very small. For any machine learning to work, we need a large amount of data actually. So we're in the process to see if we can spend a bit more time. The reason I'm mentioning at this community, because this is really quite helpful for someone who's got Rett syndrome, where we could get the EEG monitoring remotely. It's much more easier to apply when the child is sleeping, and the sleep is the best time to capture these seizures for a long term. And by having a machine learning algorithm, we could handle a large amount of data which is not reliant on a specialist. So I will stop there, and obviously this work is not possible with funding, and we're funded by Base Center and the UKRI for this, and then a group of engineers and the physiologists who are working on this. And I'm going to stop there, and thank you for your attention.